Thank you very much. It's hard to follow something like this. I mean, obviously, you know, we all have a lot of work to do. I'm going to talk about integrative health, and been listening a lot to, you know, what people have talked about this afternoon, and a lot of resonates very much with the needs of the obviously huge problem of TMD, but also what integrative health wants to offer, whether or not it can at the present time, but it's at least a goal. So I'm going to just read the definition. Integrative health care brings conventional and complementary approaches together in a coordinated way. It emphasizes a holistic, patient-focused approach to health care and wellness, including mental, emotional, functional, spiritual, social, and community aspects, and treating the whole person rather than, for example, one organ system, and I would add one body part. So clearly, you know, there's a great need for integration. I have heard the word integration said over and over and over again today. I wholeheartedly agree. I think we need to all come together. And I was actually talking with Dr. Sluka during the break, and we were saying, well, integrating, it's really important to think, what do we want to integrate? It's not just taking conventional medicine and then picking a couple of things like acupuncture and chiropractic care or something and adding it to it. It's really developing a comprehensive system of care that will include all the available options that patients can, you know, choose in conversations with their healthcare providers to decide what's best for them. So that could include, of course, a lot of cell care, for example, very important options like physical therapy, psychotherapy, all those things. So we've heard this already a million times. Complex pathophysiology, structural and psychological components. No one size fits all. And I think, you know, hopefully integrative health is an opportunity for personalized, multimodal, mind and body, means whole person care. Now, I am going to, this is what integrative healthcare wants to be. Now, the question is, we should have all the answers, right? Obviously, we don't. We have little baby answers. And my task for preparing for this talk today was to go through the literature and see what is the evidence on complementary and integrative interventions for TMD. I was very, you know, I did not find a whole lot. So what I'm going to show you is what's available in the literature of solid evidence. And so I went to the top of the pyramid as well to meta-analyses and saw what is it that we have, where we're not just citing studies with 15 patients or, you know, what do we have that we can actually say, you know, we can trust as far as evidence. So I'm going to talk about three things now. Cognitive behavior therapy, acupuncture, and dry needling, and manual therapy. Now, Dr. Drangsholt already mentioned cognitive behavior therapy, so I'm not going to dwell on it too much, but I'll show you what at least I was able to find. So there is one Cochrane's database systematic review dating from 2011, and I apologize, this is small, so I'm just going to point to the important pieces. And this was the effect of cognitive behavior therapy on pain intensity long-term, so greater than 3 months. And so this is where cognitive behavior therapy was compared with usual care. And what overall, if you look at the bottom here and you see this tiny little dot, it shows a statistically significant effect, meaning that, you know, there was enough evidence to say, yes, this is significant statistically, but the effect size was 0.34 in favor of cognitive behavior therapy. That is considered a small to moderate effect. So it is not insignificant clinically, and so we can at least say that for patients, that is an option, that there is some evidence behind it, okay? So what about acupuncture? Applying the same logic, looking through the literature, I was able to find one meta-analysis of acupuncture, and this one was interesting from different ways. So It was not the highest quality meta-analysis, on the other hand, that you would want, but you can still look at what the results were. The interesting thing here, again, is that there were some statistically significant differences. The way you can tell it's statistically significant is if the little diamond here in the forest plot touches the line or crosses the line. And so here, overall, there was a statistically significant effect of acupuncture versus a control group. And I'll talk about the different control groups that were used. So this meta-analysis, however, was flawed in the sense that they did not offer the effect size calculation. There was no pooled standard deviation that was calculated or used. And so you can't really tell whether the clinical significance truly is. But what you can look at is the raw result, where the improvement from 0 to whatever average effect there was about the order of 1 point on a 10-point pain scale, which is not very, does not reach clinical significance, okay? What was interesting here is that, now this could be a slightly changed if it was calculated as an effect size, but we don't have that data. The interesting thing here that I want to point out is that there was a difference between whenever this comparison was not to usual care. It was to a sham treatment. So if these had been compared to usual care, it's likely that the effects would have been much greater. And this is all over the acupuncture literature. And acupuncture typically, for other conditions like back pain, neck pain, knee pain, gets effect size of about 0.5 when compared with usual care. But when you compare it with a sham, you typically get about this, effects of 0.2, 0.25, something like that, which is what I'm guessing this would be. But the interesting thing here is it depends on what kind of sham you use. So sham acupuncture comes in different flavors. You can use a treatment, the aim of a sham treatment is to mimic acupuncture like a placebo, so that patient believes they've had acupuncture, but it's not actually acupuncture. How do you do that? You can do what they call minimal acupuncture, where you're barely pricking the skin. And that, you ask people at the end of the treatment, do you believe you had acupuncture? And if the same number of people in the sham or real group guess correctly, then you know your sham has been successful. Another way to do a sham is by not penetrating the skin and using kind of like a telescopic needle, where the needle goes back into the handle, and patients see the needles, they think they've had acupuncture, but they haven't. They haven't even penetrated the skin. These sham treatments are actually quite sophisticated. The field of acupuncture has done a great job coming up with shams out of necessity. And when you compare what's called a penetrating versus a non-penetrating sham, this is what you see. Non-penetrating sham, the difference between real acupuncture and the non-penetrating sham is always greater than with the penetrating sham. What does that tell you? Well, a lot of people think that the very act of very, very slight needling actually does something. And, a lot of times when people in the field think, well, that's just an excuse, But I'm going to show you some interesting data that really is quite provocative. This is data from Rick Harris at the University of Michigan. Now, this is a study of fibromyalgia, which is obviously very different from TMD, but I'm showing this because to show you that sometimes there's more than appears at first glance. What they did is they measured a pressure pain threshold on the thumb, and then they applied either a real or sham acupuncture. What they found is people who had a high pain threshold at baseline, so people who were not very pain sensitive, you could push a lot on their thumb before they said it hurt. These patients responded well to the real acupuncture, the Verum, but did not respond to the sham, as you can see here. The opposite happened with people who had the low pain threshold. People who were very sensitive, they did not respond to the real acupuncture, but they did respond to the sham. And this is there's a statistically significant interaction between the pain threshold and the response to the treatment. What does that tell you? Well, there's possibly an indication that people who have high sensitivity to pain at baseline can have effects from extremely minimal treatment that you would think this treatment is doing nothing, but in fact it was actually doing something. This does not look like a placebo effect. So this is very interesting, and I think it needs to be pursued further. And I think because we know that pain threshold is important, as we were finding out in Dr. Maxner's studies, I think this is something that we need to think about. I don't exactly know how you would apply this to TMD research, but I think this is an interesting finding. Another way in this meta-analysis that they sliced and diced it is they looked at different types of what they call the diagnosis. And after this ontology session, I feel a little bit sort of nervous showing this slide to you, but whatever. So what they said is they divided the types of patients into two types. One they called myogenous, and the other one they called arthrogenous. Now, reading the meta-analysis, it's not entirely clear how they did that. I would have had to go through every single paper to be able to see, and I didn't have time to do that. But I'm trusting that there was enough in the studies to point to either a difference in how the patients presented. And I think that, if this is correct, it's interesting to see that the people who had myogenous type seem to respond better to acupuncture than those with arthrogenous type. So why could that be? Well, there's something called myofascial trigger points. And this is something that has been in the literature for a long time, I would say 50 years. Nobody exactly knows what these things are. There are clinical phenomena that people can observe all over the body, areas that are focally hypersensitive to touch. And when you insert an acupuncture needle at those spots, you sometimes observe what's called a jump sign, or the muscle twitches and then relaxes. There's a profound, when you actually hit one of those points and you do it right, there's a profound muscle relaxation that occurs. Sometimes when it works, patients feel a lot of relief. Now, a lot of times these trigger points come back, but it's just really instant, and it's very interesting. And we don't understand the physiology of this. Now, these trigger points are located in various parts of them. You have them, like some of them are described here. This is purely empirical descriptions in the masseter muscle here. And the pain typically from a trigger point radiates. It's not exactly right at the trigger point location. It can go elsewhere on the face here, you can see. But also importantly, you can have trigger points in the neck that radiate to the jaw or to other parts of the face. So these trigger points are important, and I think that it's important as a diagnostic test that anybody who would have pain in the jaw, I mean, I would think it would be very important to go see if they might have some trigger points in the neck or elsewhere in the head, and that could be released. And sometimes they come in chains. Sometimes these trigger points, they can go all the way down, to the back, and you can kind of find them and release them one after the other, and it's quite interesting. So again, the idea that the body is not a set of disconnected pieces, right? It's connected. So manual therapies is the next thing I'm going to talk about. And again, the idea with these manual therapies is that we are not disconnected pieces. The body is a whole. And a lot of the manual therapies really think that way. A lot of people who do massage, who do something like called Rolfing or myofascial release or those types of treatments, they really think in a whole body kind of way. And one of the things that, one of the types of manual therapies is called, that chiropractors, for example, do in osteopaths, is called spinal manipulation, and also soft tissue mobilization. These are two techniques that are used. They're not mutually exclusive. Sometimes a practitioner will do both of these techniques in the same visit, or different depending on how they feel what is necessary. The spinal manipulation is a quick, what's called a high velocity force, and it's aimed at sort of loosening parts of the spinal ligaments, that have become sort of adherent or stuck, and to just induce a sort of a snapping kind of situation where the muscles very often relax. It can be also very dramatic. The mobilization is a longer sort of stretching kind of motion that sort of pulls on the tissues. Now, I was not able to find any systematic reviews or any type of analysis of chiropractic for TMD or these types of manipulation. But I was lucky enough that my colleague from Brigham and Women's Hospital, Peter Wayne, sent me this nice meta-analysis that is now in press I didn't actually write the reference on it. It's in Journal of Pain, I believe. No, it's in headache, for migraine. And because there's there's a spinal manipulation for migraine, and because there's a lot of comorbidity between TMD and migraine, I thought I would show you this. And so spinal manipulation had, again, a small effect, minus 0.28, but you can see statistically significant in favor of spinal manipulation. So I think we're going to hear more about this. One quick point here is safety. CBT and acupuncture are generally considered safe. Cervical spinal manipulation does carry a small but real risk of vertebral artery dissection. Typically, unfortunately, it also, there's a lot of debate about the risk of this. There's people argue about this, how frequent. The estimate is about 1 in about 200,000 manipulations, so it's not a big risk, but it probably needs to be disclosed to patients. So in summary, meta-analyses of randomized clinical trials, CBT and acupuncture, statistically significant but small magnitude benefits compared with usual care for CBT and sham for acupuncture. Dry needling for myofascial TMD, whatever that is, if you can define it, warrants more investigation. Measuring pre-treatment pressure pain threshold may help with individualizing the dose of acupuncture. And finally, although manual therapy and spinal manipulation are commonly used clinically for TMD and have shown some promise in treating migraine, there are very few studies testing their effectiveness. Thank you.